Welcome to the second installment in the webinar series, Transforming Our Response, Practical Tips on Providing Trauma-Informed, Culturally Safe Care for First Nations, Inuit, and Métis women, girls, and gender diverse people. My name is Laura Bouchard, and I'll be your webinar moderator for today. This webinar, presented by the Native Women's Association of Canada, is hosted by the Canadian Public Health Association. Our offices are located on the original unceded territory of the Algonquin Anishinaabe people. They've been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. This webinar series, brought to you in partnership by the Native Women's Association of Canada and the Canadian Public Health Association, aims to offer health and social service providers practical tips on providing trauma-informed care, specifically for Indigenous women, girls, and gender diverse people, using a case-based instruction model. Over the series of 3 webinars, we've been exploring how trauma can impact an individual's experience when accessing care and how providers can respond to reduce barriers, improve communication, and enhance compassionate, effective care for Indigenous women, girls, and gender diverse people. Thanks for joining us today for webinar 2. The link to register for the final webinar on May 22nd is available on screen and will be provided again at the end of today's webinar. Recordings for all 3 webinars will be made available if you've missed any of them live. So we're very excited to be collaborating with the Native Women's Association of Canada to put on these webinars. And the timing could not have been better because CPHA has recently put out some new resources focused on applying trauma and violence-informed care. These resources were produced as part of our project that centers on reducing stigma related to sexually transmitted and bloodborne infections. The TVIC toolkit, pictured on the left, supports self-reflection, organizational assessment, and monitoring and evaluation towards adopting a trauma-informed approach. In addition, pictured on the right, an entire professional development workshop has been developed in a turnkey format with all the tools to get you started on delivering training in your own workplace or region on applying the principles of trauma and violence-informed care to support reducing STBBI stigma. So you can check out our project webpage or get in touch with us for more information and support. And without further ado, I'd like to introduce our wonderful presenters. So we're going to be hearing again today from Anne Seymour and Abrar Ali. Anne Seymour is an Ojibwe registered member of Wikwemikong unceded territory and is currently a PhD student at Carleton University. Her research interests include working with Indigenous communities, incorporating land-based activities to improve mental health and suicide prevention, at the same time as walking in 2 worlds. Her most recent work experience was centered on mental health first aid First Nations as a master trainer and co-facilitator, and healthcare in British Columbia with Fraser Health. Abrar Ali is an internationally trained physician who practiced medicine in Dubai. In Canada, Abrar provided primary healthcare on the Indigenous Reserve Akwesasne. She observed firsthand the health issues the community was grappling with and came to appreciate Indigenous culture and their holistic approach to well-being. The gaps in the healthcare system and the health disparities that exist between Indigenous and non-Indigenous populations in Canada stimulated her desire for change. She obtained a master's in public health and has since been working for the Native Women's Association of Canada. She's passionate about equitable access to quality, culturally safe, compassionate healthcare. So thanks so much, Anne and Abrar. I will now hand it over to you to begin today's webinar.
Thank you for the kind introduction, Laura, and welcome everyone to the webinar. Ani Dejnakaz, Anne Seymour, Wikwemikong Dunjaba. My name is Anne Seymour, and I am from Wikwemikong unceded and unsurrendered territory located on Manitoulin Island here in Ontario. My preferred pronouns are she and her. Chimigwetch for taking the time to sit with us as we journey throughout this presentation, focusing on working through trauma-informed care with Indigenous people. Specifically, today we'll be addressing Métis people. It is my absolute pleasure to co-facilitate this session with Abrar Ali. I'm hopeful that you will take something away from this presentation, and what you don't need, you can leave behind.
Good afternoon, folks. I'm Abrar. My preferred pronouns are she and her. We're thrilled to have you join us today. We're hoping to have a fulsome discussion and welcome questions and comments from you throughout our talk. We'll be answering your questions at the end of the webinar. So as Laura mentioned, we are from the Native Women's Association of Canada, NWAC for short. NWAC is a national Indigenous organization founded on the collective goal to improve, promote, and advance the social, economic, cultural, and political well-being of First Nations, Inuit, and Métis women, girls, and gender diverse people. NWAC became a nonprofit organization in 1974 and includes 13 Indigenous women organizations from across Canada. At NWAC, we're committed to focusing efforts on improving Indigenous health indicators and obliterating existing health disparities and negative outcomes. I'd also like to take a moment to acknowledge Indigenous Services Canada, who provided the funding that made this webinar possible. So today, we will go over a case of a rural Métis woman. We will define trauma and discuss trauma and resilience amongst the Métis population in Canada. We will go over the effects of trauma on the individual, family, and community, and talk about retraumatization. Finally, we will define trauma-informed care and use the case to apply the principles of trauma-informed care. Before we move on to the theoretical portion of our webinar, we wanted to read out a case. This case is fictional and written by the authors of this webinar. Any resemblance to persons, living or dead, or events is purely coincidental. We will revisit this case later on, but for now, we encourage you to think about the elements in the case as we move forward with the theory. So Rebecca is a 32-year-old Métis woman from a rural Métis community in Saskatchewan. While she's sitting in the waiting room, a colleague tells you that Rebecca and everyone from her community are difficult patients who never listen. He goes on to refer to her as the patient from hell, who thinks she knows everything. When Rebecca comes into the examination room, she is short with you. She plainly says she has a yeast infection and needs a monostat prescription. She refuses to provide additional health information and does not consent to an examination. Instead, she repeats her request for a monostat prescription, stating she will not provide you with more information so you can manipulate her and make her consent to something she does not require. She says that she will not allow you to touch her body and harm her like her auntie was harmed by the racist healthcare system. You know that many women from Rebecca's community have come forward with allegations of forced or coerced sterilization and other negative healthcare experiences. Rebecca remains firm in her stance. You are not sure how to proceed. So to start off, let's talk about trauma. What is it? We can use the 3 E's to understand trauma. The first being events. Trauma can occur at any time in an individual's life. It is often unexpected, outside the individual's control, who is often unprepared for the event. The event is often overwhelming and threatens an individual's physical, emotional, and spiritual, mental well-being. The next E is experience. An individual's experience of the event determines whether it's traumatic or not. We all experience trauma differently. What may be traumatic to one individual may not be traumatic to the other. Those who have opportunities to talk about and process the events while feeling supported by their social support network are often able to integrate these experiences into their lives without lasting effects. Nonetheless, there is no specific measure that indicates individuals are either fully recovered from a trauma experience or not. The next E is effects. Trauma may overwhelm an individual's capacity to cope. The individual may find ways to cope with their trauma that may work for them in the short term, but lead to adverse physical, social, emotional, and spiritual effects in the long term. In general, trauma can be further categorized into loss, like sudden illness, death, or divorce, abuse, including physical, emotional, or sexual, and chronic stressors, like poverty or racism. I will now pass it on to Anne, who will talk more about the Métis people of Canada.
Thank you, Abrar. The Métis are one of 3 distinct Indigenous populations in Canada. In French, the word Métis is an adjective referring to someone of mixed ancestry. The Métis are descendants of those born to Indigenous mothers and European fathers. However, it is important to note that being Métis is more than having mixed Indigenous and European heritage. In fact, Métis have a distinct history, culture, language, and territory unique from Indigenous or European roots. Métis are not one of the same as First Nations people, when in fact, Métis are distinct that have separate cultural values and beliefs. Métis nations originated largely in Western Canada and emerged as a political force in the 19th century. They traveled outwards from the Red River settlement. While the Canadian government politically marginalized the Métis after 1885, they have since been recognized as an Aboriginal people with rights enshrined in the Constitution of Canada and more clearly defined in a series of Supreme Court of Canada decisions. The Métis Nation are descendants of fur traders who settled in present-day Manitoba along the Red and Assiniboine rivers, referred to as the Red River Colony. We would also like to note that there are others outside of the Métis Nation who do not have connections to the Red River Colony, who also identify as Métis, particularly in Quebec and the Maritimes. In this family portrait we see here, we see the blending of two cultures. The father wears a European suit adorned with a pocket watch. The mother holds their infant in a cradle board, traditionally used by First Nations people, and the shawls worn by several of the women and girls reflect Métis culture. Métis people have acted collectively to protect and fight for their rights, lands, and ongoing existence as distinct Indigenous population. Next, in this slide, we look at some misconceptions regarding the Métis people. People would often think of Métis as a group that were considered of mixed blood. The assumption is that Métis were considered half white and half Indigenous. Historical trauma and structural racism generate systemic abuses and marginalization for Métis women, making them vulnerable to abuse. Les Femmes Michef, Women of the Métis Nation organization, consulted with Métis women and learned that the loss of culture and community contributed to an increase in violence amongst Métis young women. LMFO identified some disturbing trends. Some of these trends included young Métis women experience more aggressive forms of violence, such as bullying, drug use, involvement with gangs, poverty, and a lack of family support. Young women tolerate and accept derogatory references from their partners, such as referring to them as their bitch and other demeaning labels as a sign of endearment. These experiences have compounded to create a collective trauma felt by Métis women and girls. A trauma-informed lens is based on the tenets such as understanding the unique histories of Métis people. It is hugely important we acknowledge the Métis are a distinct people. The Métis have been affected by colonization. A trauma-informed lens will embrace a non-judgmental, strength-based approach and honoring differences, choices, and compassion. It is also important to include Métis-specific values such as kinship ties, faith, spirituality, food, and respect for life that includes land and water. The Métis were further discriminated against in residential schools and were not allowed to use the same dining halls or student residences as other students. Métis children remember being the outsiders to the residential schools. In some cases, Métis people were told they were too white for the Indian schools, or in other cases, told they were too Indian for the provincial school system. From 1885 to the mid-1900s, poverty, demoralization, and racism, commonly connected to being identified as a half-breed, led many Métis to deny or suppress that part of their heritage if they could. The Métis were referred by some as the forgotten people, because after the 1885 Northwest resistance and up until the 1980s, the Métis were not on the national radar. That changed with the constitutional recognition and a number of court cases that brought Métis issues into the national spotlight. The Métis Nation are descendants of fur traders who settled in present-day Manitoba. There's a shared culture, traditions, and language among those who trace their family roots back to the Red River Colony. There are other outsiders of the Métis Nation who do not have connections to the Red River Colony who also identify as Métis, particularly in Quebec and the Maritimes. The Royal Commission on Aboriginal Peoples referred to them as the other Métis and said they constituted a minority within a minority within a minority. Métis attendance at the residential schools often went unrecorded and there was no consistent records kept. Indigenous people are often seen as resilient, Métis included. A combination of factors supports this claim. Indigenous people have found the strength and courage to embrace their culture and retain a strong sense of identity. Further, a reclamation of their language and accessing Indigenous people continue to live with trauma each day and through various coping skills and supports addressing trauma is a reality Indigenous people face. By the early 19th century, Catholic missionaries arrived at the Red River and brought with them gender norms and expectations that sought to confine Métis women into strict roles that soon made them politically, socially, and economically inferior to Métis men. These norms were quickly worked into legislation and were later reflected in media and worked to erase the various contributions of Métis women to their communities and greater society. There has been much Métis resistance to these colonial impositions, such as the Northwest Resistance and the Red River Rebellion. The breakdown of Métis communities and their families, as well as the events following these resistant movements, led to even greater marginalization of Métis women. Residential and day schools compounded the issue further, and impacted generations to come, which led to increased child apprehensions among many Métis families, not only due to trauma, but also because of negative stereotypes regarding Métis women and their ability to parent. Rather than being seen as the strong, independent, and contributing Métis women and girls frequently find themselves in vulnerable situations, such as homelessness, poverty, and food insecurity. While we aim to take a disaggregated approach to our work, Métis-specific stats are very challenging to source. We recognize the unique cultures, experiences, and way of knowing among First Nations, Inuit, Métis populations in Canada. However, we also recognize that Indigenous populations have poorer health outcomes, higher rates of heart disease and respiratory illnesses, such as stroke, diabetes, and STBBIs. A disaggregated distinction-based data is needed. Next slide, I'll talk about the effects of trauma. In order to provide trauma-informed care, but understanding the effect of trauma on the individual, family, and community, is important to become trauma-informed. Here we look at the 4 distinct quadrants of the mental, emotional, physical, and spiritual health of an individual. In the mental component, we look at self-harming behaviors, substance misuse of drugs, alcohol, and other solvents. We have a misuse of gambling, attention-seeking behavior, isolation, violence, and risky behavior. In the emotional quadrant, we look at depression, eating disorders, mood swings, guilt, shame, self-blame, self-hatred, and anxiety, which leads to panic attacks. In the physical component, we look at the chronic pain. We see obesity, diseases such as heart disease, liver disease, chronic obstructive pulmonary disease, STDs, and early death. And finally, in the spiritual component, we may see an individual questioning their purpose, their self-worth, and feeling that life has little meaning, questioning the presence of a greater power, and feeling disconnected with the world. The individual may believe that there is evil and the entire race and culture is bad. The effects on the healthcare system, we look at an individual who may repeatedly miss or cancel appointments. They may avoid preventative care and may have poor adherence to medical recommendations and also have anxiety about certain medical procedures. In the next slide, we talk about retraumatization. An individual who has experienced trauma is vulnerable to retraumatization. This is when a situation or environment resembles their original trauma and triggers similar reactions experienced with the original trauma, including, but not limited to, fear, anxiety, terror, grief, or anger. Although often unintentional, there is a potential for retraumatization within the care setting. Attempting to avoid retraumatization is crucial, as individuals who are traumatized multiple times are more likely to exhibit trauma-related impacts. They are also less likely to seek and engage in treatments and interventions. Before we move on, I think it's imperative to note that healing and recovery from trauma is not linear. Survivors may be willing to participate in treatment in one visit, but not the next. This can change from day to day and in the long term as well. Therefore, practitioners, helpers, and healers need to continuously check in with individuals and respond with empathy and understanding and adjust the treatment plan accordingly. In general, a trauma survivor must be respected for where they are at in their journey. The trauma survivor takes the lead, and we as helpers guide and support them along their journey.
Thanks, Anne. Now for the big, seemingly complicated question: what is trauma-informed care? Trauma-informed care is a holistic, strength-based framework based on open-mindedness and compassion. It promotes positive health outcomes, empowerment, and healing. Trauma-informed care is grounded in an understanding of the pervasiveness of trauma and the wide impact trauma has on the individual's physical, mental, emotional, and spiritual health. Trauma-informed care is understanding without judgment where the individual is coming from. It incorporates an awareness that individuals have different pathways to healing and utilize varying coping mechanisms to manage their trauma. It also means understanding that they may never conclude or come to a place in space where they are comfortable or coping with their coping mechanisms. Trauma-informed care seeks to actively resist re-traumatization and acknowledges the special needs individuals managing trauma require within the care setting, while creating opportunities for survivors to rebuild a sense of control and empowerment with a purpose to live a fulfilling life directed by them. To understand trauma further, let's use the Substance Abuse and Mental Health Service Administration's 4 R's. The first R being realize. We need to realize the widespread impact of trauma and understand the potential paths for recovery. Trauma-informed practices are ones that are able to understand that trauma is complex and exists within all of us. They are able to understand that there are intersecting levels of oppression that affect certain populations more than others. They can set aside their personal beliefs, stereotypes, and opinions on marginalized populations long enough to address their needs. The next R is recognize. We need to recognize the signs and symptoms of trauma in clients, families, and others involved within the system. This may not be easy, as everyone has different coping mechanisms and ways in which they handle and show trauma. Understanding the difference between who a person is and the symptoms or coping mechanisms that trauma can cause is important for developing a needs assessment. This recognition is important so that people's behavior or responses aren't treated in a way that further alienates them. The next R is respond. We need to respond by fully integrating knowledge about trauma into policies, procedures, and practices. Responding doesn't mean calling someone else to deal with a person because we don't have time to deal with the way they're acting. We need to find the time and understand that every human is worth it and meeting them where they are and safely communicate what that person on their needs in that moment. And finally, resist. We need to seek to actively resist re-traumatization. We covered different ways a survivor can be re-traumatized within the care setting. We need to be mindful of the triggers and communicate with patients and clients as much as possible, while remembering that just because they were okay with something the last visit doesn't mean they're okay with it now. The key to avoiding re-traumatization is communication. Ask questions about comfort level and respect the individual's boundaries. According to the Substance Abuse and Mental Health Service Administration, the principles of trauma-informed care include trauma awareness, safety, choice, collaboration, and empowerment, strength-based, and trustworthiness. Anne and I will now go over these principles and apply them to the case we outlined in the beginning of the webinar. Anne will remind you of that case.
Thanks, Abrar. Rebecca is a 32-year-old Métis woman from a rural Mayte community in Saskatchewan. While she is sitting in the waiting room, a colleague tells you that Rebecca and everyone from her community are difficult patients who never listen. He goes on to refer to her as a patient from hell who thinks she knows everything. When Rebecca comes into the examination room, she is very short with you. She plainly says she has a yeast infection and needs a monostat prescription. She refuses to provide additional health information and does not consent to an examination. Instead, she repeats her request for a monostat prescription, stating that she will not provide you with more information so that you can manipulate her and make her consent to something she does not require. She says that she will not allow you to touch her body and harm her like her auntie was harmed by the racist healthcare system. You know that many women from Rebecca's community have come forward with allegations of forced or coerced sterilization and other negative healthcare experiences. Rebecca remains firm in her stance. You are not sure how to proceed.
Thanks, Anne. So trauma-informed approaches often begin with building awareness of the prevalence of trauma, its impacts on individuals, families, and communities. It also incorporates an understanding of the coping mechanisms individuals use to manage their trauma. Let's look back at Rebecca's case and think about how we could have applied trauma awareness. The most important thing to understand in Rebecca's case is that trauma can not only impact the individual, but can also extend to families and community. This case speaks about the horrific historical and ongoing sterilization of Indigenous women without free, prior, and informed consent. As recently as April 2019, over 100 Indigenous women from 5 provinces have come forward to say that they were forced or coerced to undergo a sterilization procedure in Canada. This no doubt has a huge impact on these women, their families, and communities, and greatly impacts how they trust and interact within the healthcare setting. While Rebecca may appear argumentative, she is probably struggling to regain or hold on to personal power and grappling with trust after enduring what her family members and community have gone through. Please remember that trauma isn't always as evident like we've written it out in this case. Part of being trauma-informed is being aware that more often than not, individuals you're working with have experienced some kind of trauma. And as a care provider, you need to act accordingly.
It is incredibly important to appreciate and recognize silence. Giddiness and sometimes laughter may be a part of coping with trauma. Although this may present as odd behavior, it may be someone's way of addressing an awful situation until they are comfortable to bring the issue forward.
The next principle we're going to talk about is safety. Ensuring the physical and emotional safety of individuals accessing health and social services is integral to trauma-informed care, as trauma survivors can often feel unsafe within these systems. Therefore, those that are trauma-informed work towards ensuring a safe environment for their patients by adapting the physical space, providing clear information about the programming, procedure, or treatment, ensuring informed consent, and explaining predictable expectations and outcomes while ensuring privacy. Offering a running commentary on what the provider is doing while they're doing it can be very reassuring. It avoids the element of surprise and makes patients feel safe. In Rebecca's case, she was clearly feeling unsafe in the clinic and with the healthcare provider. The provider needs to actively attempt to make Rebecca feel safe. This may take time, but is not impossible. The key is consistency and communication. To make Rebecca feel safe, the provider could have started the encounter by introducing themselves, explaining the nature of the appointment, asking Rebecca how she wished to be addressed and what her expectations for care were. The most important thing after that is to respect Rebecca's wishes and allow her to be in control of the encounter. Additionally, the provider could reassure her that her consent to any procedure, examination, or treatment can be withdrawn at any time without penalty to her, and that she can ask that the examination or treatment be paused, slowed down, or stopped whenever necessary to lessen her discomfort or anxiety. Rebecca can be offered a chaperone, social worker, or Indigenous liaison officer, where she can run her medical situation by them, if she wishes, to get a third, neutral party's opinion before proceeding. In a nutshell, to ensure safety, consistent communication while respecting choice and boundaries is essential.
As healthcare providers, we may want to arrange the room in a welcoming manner. The physical space can have a Métis sash or Mayte flag hanging, or a place somewhere within the space. You may consider a violin or photos of dancers jigging. Ultimately, if you're unsure, you could reach out to the clientele and ask them for some direction.
An important element of safety is cultural safety. Healing can only happen when you give someone back their identity and purpose. We like to think of the journey to cultural safety as growing a plant from a seed. This is a process that requires love, attention, and resources. Think of cultural awareness as the seed that you plant in the ground. This is the stage where you are aware of your own positionality and the difference between yourself and those seeking your services. Next comes cultural sensitivity, which is when the person takes initiative and looks into the complex histories and current experiences of Indigenous populations. Unfortunately, media attention that surrounds Indigenous populations tends to focus on negative aspects of Indigenous cultures and stories in which there is scandal or treatment inequality. They tend to reinforce the stereotype, which makes it easy for society to continue to oppress Indigenous populations. The ability to look past these stereotypes and figure out why they exist instead of blaming or formulating shallow opinions is important to cultural sensitivity to be achieved. At this point, the person can start to work towards cultural competency. Cultural competency can be achieved when the practitioner has an understanding and skills in order to be able to give care to Indigenous populations. The practitioner should be aware of the common social determinants of health that Indigenous populations face and the best way to adapt the care that is needed. They should be able to empower clients through their understanding and respect for Indigenous practices and focus on providing both Western and traditional healthcare options while giving care. The three of these steps together results in cultural safety and humility. This is when the service provider is able to acknowledge when they make mistakes and ask questions in order to learn more. Acknowledging that they've made a mistake and they're still learning can set a tone for the interaction. It keeps the interaction positive and can make someone feel heard or valued. So as you could see, one cannot be culturally safe just because they want to or need to. Rather, like plant care, they need to continuously care for it, put resources into it, and watch it grow from a seed. This also means that once one becomes culturally safe, their work does not stop. Instead, cultural safety is continuously evolving and changing, and so should the individual seeking it. The next principle is choice, collaboration, and empowerment. Choice, collaboration, and empowerment are vital in facilitating healing and avoiding retraumatization, as choice increases an individual's control, self-efficacy, and self-determination. This in turn improves effectiveness of services and increases the individual's willingness to engage in treatments, supports, and interventions. Providers can establish choice by providing clear messaging about patients' rights and responsibilities. Going back to Rebecca's case, Rebecca seemed to know exactly what she wanted. The care provider, on the other hand, likely needed more information because while her symptoms may very well be a yeast infection, there is a big chance that other illnesses may present in the same way. The provider could have given Rebecca more control by allowing her to obtain her own swab rather than undergo an examination. Further, the provider could have also adopted an informed choice model. This is where they lay out various next steps and options. Educate Rebecca about the details, risks, benefits, and outcomes of each one, and ask her to choose the one that best fits her needs. The provider can give Rebecca an opportunity to think over her options, discuss them with a third party, or do her own research online before deciding on what to do. When possible, the provider should ensure that she knows she can take her time so that she does not feel rushed or pressured to make a decision. I would also like to note that asking her to do her own research or consulting a third party does not exclude the provider their responsibility to inform Rebecca of their options. This step is something that can be done afterwards and not instead of. The most important thing after that is to respect the decision, even if it differs from what the provider thinks is the next best step. The next principle is strength-based approaches. Now, these are vital to trauma-informed care, as they allow recipients to focus and build on their strengths, while empowering them to advance their resiliency and coping skills. A strength-based approach provides the opportunity for the individual to be in control of their care. Strength-based approaches often mean moving from what's wrong with you to what's happened to you.
A strength-based approach will support the individual's pace and allowing for silence, time to think, and maybe just sometimes to just be. All these are critical elements to support the person where they are.
Trustworthiness is the final tenet of trauma-informed care. Now, this is a big one in Rebecca's case. The provider needs to work towards gaining Rebecca's trust again. This will not happen in a day, but rather is something the provider needs to commit to and consistently work towards. A provider can demonstrate trustworthiness by communicating openly, clearly, and consistently, establishing boundaries, clarifying what's expected, and providing choice for treatment. Trustworthiness promotes collaboration, equalizes power imbalances, and allows the expression of feelings without fear of judgment. The provider needs to meet Rebecca where she is, respect her boundaries, and follow her lead.
Again, silence has been raised several times, yet this is critical to understanding your work with Indigenous people. It doesn't mean we have nothing to say. Rather, it means you are providing the respect, time, and space for someone to be. Additional tenets of trauma-informed care. Remember, working with individuals who have experienced trauma can be difficult, emotionally draining, and can lead to feelings of hopelessness, anger, and disbelief for the provider. It's important to remember to be respectful because abuse undermines an individual's personal boundaries and autonomy. Survivors often feel diminished as human beings and may be sensitive to any hint of disrespect. Self-awareness and positionality is imperative that service providers are aware of their own trauma and experiences and how they relate to their beliefs, values, theories, and biases. Also, it's important to remember to have empathy, compassion, and active listening. Demonstrating empathy and compassion helps individuals who have experienced trauma feel supported and understood and helps create a connection. Sympathy, on the other hand, leaves survivors feeling pitied, which can create feelings of shame. Empathy can often be demonstrated when providers communicate their feelings to the patient. For example, I get the sense that you are feeling sad and hurt by what happened. Simultaneously, providers need to learn to be comfortable in silences and acknowledge that often silence is a sign of communication. Providers need to demonstrate a willingness to actively listen to recipients while showing genuine interest. This can mean by paying attention to both verbal and nonverbal cues. It is important for providers to clarify anything they are unsure of, as recipients can sometimes be vague or indirect when describing trauma. Flexibility. It's important when working with individuals who have experienced trauma. Providers need to be flexible to accommodate their needs. Example of flexibility can include a willingness to accommodate the client's needs, difficulties with medical exams, and changing normal routines of procedures, or understanding if a patient repeatedly cancels their appointment or doesn't show up. It's also important to take your time. It's important to remember that feeling genuinely heard and valued is healing, and in some cases may be the most effective intervention as clinicians has to offer. Therefore, dedicating time to listen to survivors of trauma is vital. It avoids feelings of being depersonalized and devalued and enhances senses of safety and security. Finally, it's important to remember willingness to learn from the care recipients. Providers need to be willing to demonstrate humility and acknowledge that care recipients are expert in their own lives. Providers need to treat recipients as equals, allowing them the opportunity to express themselves while highlighting their strengths. Collaborating with recipients and demonstrating a willingness to learn improves quality of care. Failing to do so will reinforce power imbalances, making recipients feel weak, inferior, and risk triggering emotions of the original trauma.
So before we end today, we want to do one last exercise. Anne and I will present different scenarios. We encourage you to think about how you'd explain the individual's behavior. Can you think of a trauma-informed explanation? So in the first scenario, your patient is argumentative and combative. Now you may think that this person's being difficult, rude, or maybe they're just a bitter person. But let's try to think of a trauma-informed explanation. I'll give you a few seconds. And what are your thoughts?
The individual may be having a fight reaction. The individual could be struggling to regain or hold on to personal power.
Thanks. Let's move on to the next one. In this scenario, the individual withholds information about their symptoms, contributing to difficulty diagnosing. Now, one way to think of it is that the person's not forthcoming. Maybe they're hiding something, or they're just being irresponsible. But could there be more underneath the surface? Let's take a few seconds. And what do you think?
In this situation, an individual could be passive and avoid speaking up about their needs and feelings to authority figures, including service providers.
In this case, the individual complains of diffuse, non-specific symptoms. Then they shut down and stop responding. Now, you may think that this person is seeking attention, wasting your time and resources. There's more people that need your care. But let's try to come up with a trauma-informed explanation for their behavior. And how do you feel about the case?
This individual may have physical manifestations of trauma or disassociation.
And finally, an individual quickly becomes irritable, cries, becomes angry, and shuts down emotionally. Now, you may think that this person's being dramatic, maybe seeking attention, or all around just being difficult. But perhaps there's more underneath the surface. And what's your trauma-informed explanation?
In this situation, it's reasonable to suggest the individual may have been triggered and re-traumatized and is responding accordingly.
So the reason we did this exercise was to demonstrate to you that there's many ways a person can act that may seem difficult, but really is just the person coping with trauma. Trauma-informed care practitioners really try to find that trauma-informed explanation, even during times where it's difficult. A lot of the times providers are constrained for time. They have lots of people in the waiting room. Plenty of patients need their attention. And sometimes when someone's acting difficult, we simply don't have the time to think about what a trauma-informed explanation to their behavior could be. This is kind of an opportunity for us to sit back and really think about what could be happening in this person's life. So today we went over a case of a rural Métis woman. We defined trauma and discussed trauma and resilience amongst the Métis population in Canada. We spoke about retraumatization, defined trauma-informed care, and used the case to apply the principles of trauma-informed care. We sincerely hope you found the webinar informative. We want to take a moment to thank the Canadian Public Health Association for partnering with us on this webinar. And we want to give a special shout out to Laura Bouchard and Shireen Noble. Finally, we want to thank everyone for their time and attention today and look forward to answering any questions you may have. Thank you.
Thanks so much, Anne and Abrar, for another very informative and thought-provoking presentation. And as we did last time, we do have some time left for questions today. So we invite you now to type any questions that you might have into the Q&A box using that Q&A icon on the bottom menu there. And yeah, we'll take some time to respond to some questions. Looks like we don't have any that have come in yet throughout the webinar, so we'll just give folks a moment there to think about what some questions might be. Okay, so we have one here. How do you think these practices can be applied to interactions with police?
Yeah, thanks, Andrea, for that really great question. So trauma-informed care can be applied to any organization. So while our webinar was focused around care, any organization can be trauma-informed. And as a matter of fact, our aim is to have every organization that interacts with Indigenous populations have a trauma-informed care model within their systems. Because again, if police were more aware of the effects of trauma and how an individual responds to trauma, they're less likely to make the mistakes that they're making right now. But the key is to get into the organization and start to implement trauma-informed care wide, and we discussed this in our last webinar, how to get organizations to be more trauma-informed. And the way to get there is likely to find a champion within the organization to start the conversation with, who can, get you through the correct channels and through the right communications. The key here is the onus is on the organization and the police and not the individual. I hope that answered your question.
Thanks, Abrar. Okay, see if any more questions roll in. Okay, here we go. So we have next one. Thank you, the practical tips are so helpful. I missed the first part. So the recording for the first webinar, if you're referring to the first webinar, is a follow-up, and then also we'll be sending out the recording for today too, just to address that. So you'll be able to go back and see. The question though is there a difference in providing trauma-informed care to First Nations versus Inuit and Métis people?
This is Anne. I think this is a very good question. Thank you for the question. There's definitely, when we look at working with First Nations, Inuit and Métis, we definitely know that we're categorized in as far as the 3 different Indigenous groups in Canada. At the same time, I think it's important to understand that First Nations, Métis, and Inuit, we have different cultural beliefs, different traditions, and so I think it's important to work with the communities that are what group you're the target population that you're referring to. I think it's important to understand their traditions, some of their values and beliefs, and we have. I would direct you to their national websites. You could get information from there, or you can actually talk with the individuals and ask them what organizations they work with often, and basically just reaching out to find out information. I think it's most important to basically have those very open and transparent conversations with whoever you're working with. So there is a difference in regards to their cultural values, beliefs, and traditions.
I absolutely agree with Anne, if you don't mind me adding onto that. So Well, part of the harm that's being done, although things are getting better, but part of the harm that was done in the past was that when working with Indigenous populations, we often take a pan-Indigenous approach. And that could be really harmful because, like Anne said, each population, and even within that population, each group has, unique traditions, cultures, beliefs. So they're very, very unique and different. So I'll give you an example of what I mean. If you look at the primary mode of transmission of HIV, so human immunodeficiency virus, the primary mode of transmission amongst Indigenous populations is injection drug use. But if you look at that data and you really dig into it a little bit deeper, you'll find that while injection drug use is the main mode of transmission for First Nations and Métis people, the main mode of transmission for Inuit is actually heterosexual sex. So if you were going to use the pan-Indigenous approach to come up with a program to respond to HIV within Indigenous populations, you'll likely exclude a large section of the population because you're focusing on the wrong statistics. The same could be by using trauma-informed care. If you're going to just apply a one-size-fits-all approach, you're likely going to exclude a lot of people, especially because there are differences and variances between each group.
Great, thank you so much, both of you, for your responses to that question. We do have a couple more rolling in now, too. I just want to do more of a statement than a question, but I'll and we can see if you have any any thoughts kind of tacking onto that. So providers often label patients as non-compliant. Putting labels on patients is another example of the power imbalances seen and the racism that Indigenous people often experience.
I couldn't agree more with that comment. It's actually hitting the nail on the head, because unfortunately providers are not trauma informed and they don't understand that the way a person is acting is because of the trauma they've experienced and not just because they're being difficult. And that's kind of why we did the exercises at the very end. So I'm a care provider and I worked in the front lines in primary health care. And I found that and I heard that repeatedly from colleagues that, oh, you know what, that patient's just non-compliant, don't even try. But when you sit down with that patient and you take time, you realize that there's so much more under the surface. And all they need is for you to sit down and talk with them. Sometimes it could mean changing the medication from something that needs to be taken twice a day to once a day. Sometimes it's just walking through with them and talking about how to keep an agenda or a diary. And sometimes it's referring them to social services so that they can talk out their trauma and learn to cope in better ways. But really, this is what our aim at NWAC is. Our aim is to reach out to care providers and really nail down the difference between a person just being bitter and nasty and bad versus someone that's coping with trauma. And more often than not, people fall in the latter group, the group of people like coping with trauma.
Thanks so much, Abrar. There are more that we have here too. So how do you see trauma-informed care fitting into truth and reconciliation calls to action?
That's a really good question. So when we look at the truth and reconciliation action, when we're focusing on trauma-informed care, I think it's important that we're looking at increasing our knowledge, our awareness, and understanding in regards to Indigenous people on a whole. I think it's important not to basically identify, as we can understand, like our Indigenous people across Canada on a national level are often stigmatized and stereotyped in regards to always looking at someone as that drunk and dirty Indian, or we're always looking for handouts. So I think it's important to understand that our people, when we look at the residential schools, it's important to understand the history. And once you become more familiar with the history and the impacts from colonization, the oppression and assimilation of our people, I think it provides a better understanding in regards to where we come from and our positioning. And so if you see it from a wider lens, you get a better understanding. And looking at the truth and reconciliations is basically moving forward with a better understanding. Miigwech.
Thanks, Anne. We do have still just a couple more I see here. If you're still okay answering a couple more questions, I know you're a little in the hot seat. There's quite a few, but I mean,
No worries.
this is really great. Yeah, okay, perfect. So there's one that was just in the chat box here. Do you have any advice for clinics who work fast-paced, high-stress, or low-resourced settings?
Mhm. Yeah, I absolutely agree that unfortunately in our clinical setting, that's a reality. More often than not, really, I don't even think there's a clinical setting that doesn't have that kind of environment. So this is a wonderful question. Thank you. My advice for you is to just communicate it with your patients. So let's say your patient came into the room and you have 15 minutes or 10 minutes or whatever time you have, let them know in the start. So they come into the room and in a non-rushed, non-judgmental manner, you could say something like, so today's encounter, we have 15 minutes. How would you like to use that time? And just allow them to know right from the get-go that that's the time that you have to discuss with this person. If you feel that this individual needs more time and more attention, you could always schedule their appointments at the beginning of your day, right before your lunch hour, at the very end of your day, so that if it does bleed into additional time, you're not using other patients' time to take care of this person. Another thing you can do is to schedule appointments on maybe days that you know are not so like high pressure, you don't have a lot of patients on that day. You could do that as well. But I found in my practice, when I communicated with my patients the time that we had for the interaction, they were very much understanding. And what we did was we just scheduled more frequent appointments as opposed to just every time something is needed. Just provide them with those opportunities and understanding, and you'll find that the person truly understands, as long as you're being respectful when you're doing it.
Thanks, Abrar. Just to add on to that, I think it's also important that everyone within the service provider agency, the organization, are aware of the clientele and the people that we're working with. That means from the time that the person or individual walks into the door, someone that's working at the front desk is aware that it's important to provide that care and be sensitive to the individual by acknowledging them and ensuring that you have water there or some tea. It's important that everybody is receptive to the individual. That way, the individual's feeling, they're not feeling like they're being rushed out, but definitely they're feeling sensitive to the care that's being provided. So I think that's important. Although that may not be your individual client that you're working with, everyone that walks in and out the door as service providers can acknowledge the client or the patient that you're working with. I think that's really important. Thank you.
Thank you so much. Really great ideas there. We do have maybe just, we'll end on this one last question that we have in the Q&A box, and we will also, you'll have the opportunity at the next webinar to ask some more questions or follow up through email if ever. There's other ones that come up, but so the last one we have here is, do you have any further suggestions when encouraging a trauma-informed care approach with gender diversity, such as trans and two-spirit and non-binary Métis?
That is a great question. Thank you for it, Denise. So NRAC's mission is to serve Indigenous women, girls, and gender diverse people. So thank you for pointing that out. We do have a fact sheet that we developed that is directed to providers, and it's all about providing care to Indigenous gender diverse people or non-binary people, including trans. And I'm happy to share that resource with you. Laura, perhaps I can send it to you and you can send it out in your follow-up email. Does that work for you?
Yeah, absolutely. That's great.
Yeah, we can absolutely send that out. And it kind of has the same idea as our webinar today, where it's very much based around practical tips. So how you could provide care in a trauma-informed, culturally safe way. So I'm happy to send it out. And if you have any additional questions, please shoot me an email and I'm happy to address it. And Laura can send out my email in that email as well.
That's fantastic. Thank you so much. And did you have anything to tack on there, or we'll wrap it up?
I'm good. Thank you.
Awesome. Okay, so thanks so much, everyone, for joining us today. And thanks again to Anna and Abrar for really a great and thought-provoking presentation. We do invite you to register for the final webinar of the series. If you have, that's going to be on May 22nd at the same time. The registration link is available on the screen, and maybe I'll just ask Shireen, if you can, to pop that link into the chat box. And before closing, I'd just also like to ask you to please take a minute to fill out our brief and anonymous evaluation survey, which will help us improve future webinars. So the survey will open when you exit the webinar platform. And we'll be followed up with slides for today's presentation and the recording. So thank you so much for your participation and have a great day. We hope to see you at the next one.